So ladies and gentlemen, today I want to talk about the initial monotherapy for high blood pressure. You see, it's very important to control and manage high blood pressure because virtually every organ in our body will be affected by uncontrolled high blood pressure. So let us see some important things about the monotherapy, the initial monotherapy. The initial monotherapy is successful in many patients with mild primary hypertension. However, single drug therapy is unlikely to attain goal blood pressure in patients whose blood pressures are more than 20/10 mmHg above goal. In such patients, initial combination therapy using two drugs is recommended. Each of the antihypertensive agents is roughly equally effective in lowering the blood pressure, producing a good antihypertensive response in 30 to 50% of patients. There is a wide interpatient variability, as many patients will respond more to one drug rather than the other. There are some predicative differences, such as black patients and older patients. They generally respond better to monotherapy with a thiazide diuretic or calcium channel blocker, and relatively poorly to an angiotensin converting enzyme, that's like ACE inhibitors or beta blockers. So you remember age and race, because age and race, those are the two important things to consider when you're starting someone on blood pressure medication. With thiazide diuretics, calcium channel blockers, and beta blockers, the rate of symptomatic and metabolic adverse effects, they increase with dose. So you need to be careful when you titrate the dose with these patients. So, but with ACE inhibitors and ARBs, we have the advantage that the side effects are mild compared to other drugs. After the initial dose, going to higher doses produces an average relatively small further reductions in blood pressure at the price of an increased rate of adverse effects. So we should limit dose titration to one step with a given antihypertensive. Like for example, for chlorthalidone, you can go from 12.5 to 25 milligrams, or for amlodipine from 5 milligrams to 10 milligrams. Beyond that, you don't see much response. Now, what about the choice of drug? Some patients have clinical reason to take a specific drug or drugs that is unrelated to primary hypertension. For example, a calcium channel blocker or beta blocker, they control heart rate. For example, if a patient has atrial fibrillation, you can start them on beta blockers because it affects both atrial fibrillation and hypertension. But in the absence of a specific clinical reason, there are three main classes of drugs that have been used for initial monotherapy. Number one, thiazide diuretics. Number two, calcium channel blockers. Number three, ACE inhibitors. Three classes. Each of these three classes of drugs has been equally effective in monotherapy trials if the attained blood pressure is similar. Beta blockers are not commonly used for initial monotherapy in the absence of a specific indication, since they may have an adverse effect on some cardiovascular outcomes, particularly in older patients. So always remember those points. Among patients in whom there is a reasonable likelihood of requiring a second drug, like for example, if you already have a sense that this patient might need a second drug, you should go for an ACE inhibitor or ARB or calcium channel blocker, because the second class can be added if additional therapy is required to achieve the desired combination regimen. So you can start with low-dose hydrochlorothiazide like 12.5 milligrams, and then you can go to 25 milligrams a day. And there is a famous trial called ALLHAT trial. After this trial, it is recommended as monotherapy in most patients with mild primary hypertension. But hydrochlorothiazide appears to be less effective and has a shorter duration of action than chlorthalidone. And there is little, if any, evidence that low-dose hydrochlorothiazide alone reduces cardiovascular events as opposed to the evidence with chlorthalidone. So, when a diuretic is used either as initial therapy or in combination with other antihypertensive therapies, we recommend, like, we should start with chlorthalidone, which produces the best outcomes. That's what ALLHAT trial showed. So it is better than hydrochlorothiazide. Clinicians should be aware that chlorthalidone is associated with certain side effects like a greater risk of hypokalemia, glucose intolerance, and new onset diabetes mellitus. So those are the side effects more with chlorthalidone than hydrochlorothiazide. Monotherapy based upon age and race. The likelihood of a good clinical blood pressure response is increased when those two things are taken into consideration, age and race. How about age? If there is an young patient, let us say less than 50 years old, they respond best to ACE inhibitors or ARBs and beta blockers. So these patients, if there is a young patient, consider ACE inhibitors, ARBs or beta blockers. But as I said, beta blockers are not commonly used for initial monotherapy in the absence of a specific indication because they appear to provide inferior protection against stroke risk. Then, what about older patients? In older patients, go with an ACE inhibitor. But if they are black people, I don't know exactly why, but black patients, they respond more to thiazide diuretics. So young patients, ACE inhibitors, and older patients, you can think of like black people or also adults age more than 60 years, they respond best to a thiazide diuretic or long-acting calcium channel blocker. However, many older hypertensive patients have a specific indication for an ACE inhibitor or ARB, including heart failure, prior myocardial infarction, or proteinuria chronic kidney disease. So, for example, if a patient has heart failure or prior myocardial infarction or kidney disease, think of starting them on an ACE inhibitor. So, those are the important things I wanted to tell you today. When you are starting someone with just one medication, think of those three classes: thiazide diuretics, calcium channel blockers, and ACE inhibitors, and take their age and race into consideration. Hopefully these things help you. If you have any comments, please leave them in the comment section. I would be happy to respond. Thank you very much. Have a nice day.